Good afternoon, everyone. I'm Dr. Chi Hong Wu from National Taiwan University Hospital. It's my great honor today to join the JIS TRS Joint Symposium. And I also very glad to follow the Dr. Sakukara to share our experience about the efficacy of transcatheter renal artery embolization in patients with polycystic kidney disease, a single center experience in our hospital. In order to diagnosis of polycystic kidney disease, we can use ultrasound as a screening tool. We can use this to monitor the growth of the cyst, and then we can use the real-time technique to do the intervention. However, this is objective tool to measure the size of the kidney. In contrast, the CT and MRI can provide the whole picture of the kidney. Therefore, it's more suitable to estimate the condition of polycystic kidney disease. The advantage of a CT is that it has a high speed, high spatial resolution, and the open gantry. The benefit of MRI is that it can provide the functional image. However, it takes a long time to scan, and then he needs a radiologist to interpret the result. As we mentioned, if we do the CT or the MRI, we can get the whole picture of the enlarged kidney due to polycystic kidney disease. We can calculate the kidney volume by the volumetric method. By using 3D reconstruction, we can do the segmentation slice by slice to finally get the total kidney volume. However, it is time consuming. As we know, we all are intervention radiologists. Therefore, we hope to have a simplified method to estimate the total kidney volume. As we know, the kidney is a aerosol-shaped organ. So if we can use this formula to estimate the kidney volume, it may save much time. And then in general condition, we will not measure the radius. Instead, we measure the diameter. So we can shift the formula from this to this formula. And then if we assume that the width and the depth is equal, we can further transform the formula into this formula. Therefore, we can have a simplified way to do this. How about the performance of the formula? As you can see, if we calculate the total kidney volume with a serologic method, as compared with the ellipsoid formula, there is a highly correlation and concordance for these two formulas. So we think that it may be a time-saving way to do the embolization, to do the evaluation for the total kidney volume according to previous article. We make two examples in our hospital. As you can see here, this is a right kidney. If we use the volumetric approach, it's 1097 milliliter. And then if we use the formula approach, it's 1200 milliliter. And then for the left kidney here, this is 900 milliliter. And then for the formula approach, it's also 900 millimeter. This is for non-enhanced CT. And how about MRI? As you can see, if we calculate the total kidney volume with a volumetric approach, it's 1065 milliliter. And then if we use the formula approach, the estimate total kidney volume is 1100. So it's quite similar with high concordance if we use the formula approach. The natural history of the polycystic kidney disease that as the time by around the patient arrive age around 50 to 60, the renal cyst will replace the renal parenchyma, and so the renal function will decrease. If we do not do anything, the renal volume will increase. Besides, there is some symptom on the side, including down abdominal plane, proteinuria or hematuria or hypertension develop. If we can do the transarterial embolization, we can control the kidney volume and then improve the symptoms and the signs of the patient. Dr. Ubara first described this kind of technique, use the transcatheter renal embolization to control polycystic kidney disease in 2000, and then recently the long-term outcome of this technique also published in 2016. According to his article, we can know that the total kidney volume will decrease at 3, 6, and 12 months after embolization. And besides, the blood pressure also can decrease, and the dry weight will decrease and improve due to improvement of the nutrition. So we think that is a benefit for the patient. In order to prove this concept, we also conduct a prospective single-center study, and then we get the info consent for all patients. We include patient aged more than 20 years old with a polycystic kidney disease under hemodialysis or peritoneal dialysis. We perform renal artery embolization for kidney volume reduction. We exclude patients who are contraindicated to transarterial embolization or follow-up less than 6 months. From 2016 to 2020, 28 patients were enrolled in this study. We perform pre-operation, pre-intervention imaging for total kidney volume estimation, and then do the renal artery embolization. 6 months after intervention, we perform CT or MRI again and calculate the total kidney volume. Finally, 1 patient has no TAE image, and the 6 patients follow-up less than 6 months were excluded. Eventually, 21 patients with a mean age of 59 years old were included in this study. We make an example for this study population. He is a 56-year-old male. He had hematuria around 600 to 700 per day and a significant flank plank. He had polycystic kidney disease under hemodialysis 3 days a week. And then he also had a coronary artery disease with understanding, and then took the dual antiplatelet therapy with aspirin and Plavix. He had congestive heart failure with LV ejection fraction around 25%. So the surgeon reject the nephrologist ask for the nephrectomy. Therefore, they referred the patient to our department for possible kidney reduction therapy. In the beginning, he had marker anemia with hemogram around 6.4, and then marker hypoalbuminemia with albumin around 2.9. He is under dialysis with creatinine 9.7. As you can see in urine analysis, the RBC value is more than 100, which means that he had a microscopy and the microscopy and then hematuria. In pre-intervention imaging, we can see that there is 2 large, huge kidney with multiple cysts. And then for the left kidney, you can see there's a image here. So in urine analysis, we also can see this effect. We do the renal artery embolization with multiple coil. We follow the suggestions from the Dr. Obala, and then we embolize it from the distal to proximal renal artery, especially to we need to embolize to the capsular artery to make our effect of TAE more significant. In follow-up, his daily urine hematuria from 600 to 100, and then no more hematuria after embolization. The body circumference from 104 centimeter to 93 centimeter. The dry weight from 64 kilogram to 59 kilogram. there is a significant improvement of his anemia from 6.4 to 12.5 hemogram, and then improve of the hypoalbuminemia from 2.9 to 4.1. And as you can see, there is a further deteriorated of the renal function from eGFR7 to eGFR5. And the 6-month follow-up images show that there is a significant decrease in size of the renal right kidney from 4,200 to 1,800, and a significant decrease of a left kidney size from 3,800 to 2,100. And then the patient also said that he had obvious improvement of his abdominal distension. And then, as we mentioned, we have 21 patients, 90 patients come to our department due to abdominal distension, and 2 patients due to hematuria. 90 patients received TAE with coil, and 1 patient received TAE with glue, and 1 patient received TAE with microsphere. As you can see, we compare with before and after procedure. There is a significant decrease abdominal circumference and a significant decrease of total kidney volume. There's a trend of increased creatinine and decreased body weight, as you can see here. Okay, so we think that the renal artery embolization can improve the symptom and signs of polycystic kidney disease. However, during our intervention, we have met some unsolved problem. First is that which one of the embolization material should we choose? The majority of we use is coils. Can we use glue or microsphere? And then if a patient have combined with the abdomination with polycystic kidney disease and ascites, is this still effect? We have one case when we do the renal artery embolization with glue. However, as you can see, the control of glue embolization from distal to proximal renal artery is very difficult. The right side it have a good opacification. However, for the left side, you can see the distal renal artery is opacified good. However, there is no opacification of the proximal renal artery. So as you can see, although in the post-procedure imagery, there is a significant decrease of the total kidney volume from 3,800 to 2,200. However, the major effect remain at the right side. The left side still have a 23 centimeter as compared with a pre-procedure is almost the same. However, for the right side, the kidney length from 22 centimeter to 50 centimeter. And how about if we use microsphere as our embolization agent? And for this patient have polycystic liver and polycystic kidney disease combination with marked ascites, we do the embolization with 100 micrometer embolizing at the hepatic branch of hepatic artery and the renal artery. As you can see, there is not so much decrease in size of the cyst after microsphere embolization, and the ascites also very dominant. So the patient said that there is not so much improve of his abdominal distension. Therefore, we can conclude that we can use a simple formula to save our time to replace the volumetric method to estimate the total kidney volume. The renal artery embolization can effectively decrease kidney volume and decrease abdominal circumference to improve the symptom and the sign of our patient. Thank you for your lesson. I'm Dr. Chen Hongwu.